Today, we are going to share a story of a man from rural area who had an ocular chemical injury while cleaning toilets. Being in a rural setting, patient did not receive adequate initial treatment. Toilet cleaner contains various different types of acids and cause acidic chemical injury, which results into a severe ocular surface damage. The patient came to our tertiary care center after 2 months of his initial injury. He presented with severe symblepharon in both eyes with persistent epithelial defect in his right eye and retained chemical precipitate on his left eye cornea. By Dua's classification, both his eyes had grade 6 chemical injury. Amniotic membrane transplantation along with tarsorrhaphy was done for both his eyes along with removal of retained chemical material for left eye. Right eye also underwent allogenic simple limbal epithelial transplant. Eventually, both ocular surface healed with dense symblepharon, fibrovascular pannus and granuloma formation leading to no ambulatory vision. In view of total limbal stem cell deficiency, we decided to do type 1 Boston keratoprosthesis for his left eye. For type 1 keratoprosthesis, host refination is done followed by suturing of assembled keratoprosthesis with interrupted nylon sutures, and in the end bandage contact lens is placed over it. BCL helps to prevent desiccation of carrier graft epithelium, thus helps in preventing persistent epithelial defects, stromal melts and necrosis. Unfortunately, BCL could not stay well in patient's eye owing to redevelopment of symblepharon. We performed amniotic membrane graft along with medial and lateral tarsorrhaphy. Eventually, patient developed a severe microbial keratitis and had to undergo explantation of keratoprosthesis and therapeutic keratoplasty. Once again, patient went into the world of darkness. This time, we decided to do type 1 keratoprosthesis in his right eye. From the previous experience, we now know that BCL is not going to retain in his eye. So, we decided to utilize the existing pannus to cover type 1 keratoprosthesis, thus eliminate the need of BCL post-operatively. Type 1 keratoprosthesis was planned under pannus. To achieve this, we started pannus dissection from superior edge so as to reflect it off the ocular surface in one complete sheet. It is important to avoid tears in pannus while dissecting. To achieve a thin sheet of pannus, excess fibrovascular proliferation underneath was excised. .5 mm partial trephination of host cornea was performed. We used AIOC2022 this time, whose design is based on type 1 Boston keratoprosthesis. AIOC2022 is manufactured in India. To assemble the K-Pro, 9 mm donor trephination with central 3 mm punch trephination was achieved. The carrier graft was placed over the optical cylinder of keratoprosthesis. Then, PMMA backplate was secured over it and titanium locking ring was fixed. Once it is assembled, we inspect the keratoprosthesis for proper alignment and locking. Host trephination was completed. Open sky cataract extraction was done. Posterior capsule was kept intact to avoid vitreous disturbance. Assembled K-Pro, then sutured to host trim with 10-0 nylon interrupted sutures. At this time, in routine keratoprosthesis, we form the anterior chamber and insert bandage contact lens over K-Pro unit. But here, we place the reflected pannus back on ocular surface covering keratoprosthesis unit and secured it with atovicryl sutures. An inadvertent tear which had occurred was also sutured meticulously. At the end of the surgery, eye looks exactly the same as we started. At day 12, a central opening over optical part of K-Pro was made in the pannus. As conjunctiva has a tendency to retract, it is important to wait for few days to achieve a correct position of optical opening in the pannus. Patient is doing fairly well till now with 6/12 vision. A keratoprosthesis requires a close and regular follow-up, but patient could not visit us for follow-ups during lockdown. As they say, if there is a will, there is a way. We monitored this patient through WhatsApp videos and images until the regular clinic visits restarted. At 6 months follow-up, his vision was reduced to 636. On examination, posterior capsular opacity and macular edema was noted. We performed YAC capsulotomy for PCO and posterior subtenon's injection of triamcinolone was given. At 7 months follow-up, patient had regained vision to 6/9. Macular edema was resolved with fairly well-maintained foveal contour. This is a story of our patient who went through so many procedures post his chemical injury. Even though keratoprosthesis has its own challenges and may even require surgical interventions in between, with regular and close follow-up, we can bring a light in their dark life.